Very common for even in the Western area, even if I take any European countries or American countries to discuss the topic of what is the utilization of the medical management post mist, because it's a very important topic as professor mentioned, but at the same time it is not at all discussed because we want mist to work completely 100% throughout the life, but in real world experience the fact is not so. So there is a need for adjuvant medical treatment. So the question is it correct, is it ethical, how far we can gauge something as success or failure? These are all very, very personal things. For a surgeon who is quite passionate on the mist like me, it's very difficult to say which is correct, which is failure, which is success, etc. I will try to talk as much evidence based and also what I feel in my heart as the correct medical practice, because end of the day our aim is to make a patient completely free of his symptoms and make his life as good as before. That is our main aim. Again, thank you, Professor, for this opportunity, and thank you for giving such a, it's a challenging topic, but at the same time, it's quite a unique topic. I really appreciate that. Now, as Professor said, I've spoken about this mist many times, like Eurolift, iTind, etc. But as we speak, as we grow, in the past 1 year itself, we came across lots of other new energies. I will try to very briefly mention that's the topic of the energies. At least I wish the audience to know the title of what energies we are discussing on. And then I will focus on the actual crux of the topic, which is the need for the medical management post mist. What is the difference between this mist and prostate cavitary surgeries? What I mean by cavitary surgeries or the prostate surgeries where we'll create absolute good cavity. So as you can easily say, the age-old gold standard is the TURP, and now the new gold standard, which is definitely going to be gold standard in the future, is the anatomic enucleation of the prostate. The difference between this cavitary approach, which is TURP or anatomic endoscopic enucleation procedures on one end with very good success relatively, and on the other end this minimalist approach of minimally invasive surgical treatment. The main difference is the mist, as the name suggests, is quite minimalist. It's a very minimal procedure. Okay. So it can't be compared to something which requires anesthesia, which requires maybe transfusion, which requires catheter irrigation, overnight stay, etc. etc. And the other advantage of mist is most of them can be done under local anesthesia, even though individually there may be some challenges with each. And they are very suitable for low performance status patients. What I mean by that, sometimes if the patient is very crippling, say bedridden, doesn't like catheter, or sometimes cognitively not good, pulling out the catheter, resulting in bleeding, resulting in urethral injuries, etc. Mist will be very handy because it's quite suitable for patients who are, I won't say unfit patients, patients who are quite poor in their fitness. And the main thing which stands above the TURP and cavitary procedure is ability the mist can maintain both erection and ejaculation. Unfortunately, nowadays all the diseases were a bit preponed, and we can take it to anything. So if you take the average age in which the diabetic happens in 1900s, it will be around 50 or 60, etc. But now the average age of diabetics is, the starting of diabetics is coming to 40. Similarly, the hypertension, cerebrovascular accidents, cardiovascular diseases, everything there is unfortunately coming in 1 decade earlier. And similarly, the urinary symptoms also now occurring in young men at the age of even 35, 40, presenting with significant voiding symptoms. And when we do flexi, we can find sometimes quite tight bladder neck, etc. These are all due to the sympathetic tone and the lifestyle, which we can discuss in the other presentations. So for these kind of patients, it's very important for us to offer a procedure which will de-obstruct the bladder but at the same time preserve the erection and ejaculation. I've come across some patients who need this missed procedure, but they haven't even completed the family. Some of them have no children, some of them have one children, but wish to have at least two or three more. And it's very important for them to have this possibility of having the normal erection and ejaculation in spite of the bladder outlet obstruction procedure. Obviously, this mist will not produce a cavity as big as the TURP or holmium enucleation or thulium enucleation procedures. But our aim with mist is to create the cavity as big as possible, preserve the ejaculatory mechanism as good as possible. Those two are the main gold line, I will say. By not creating a cavity as big as TURP or enucleation procedures, by preserving the tissues to preserve the ejaculation, are we compromising on long-term results? My answer is yes. Definitely, mist can't give long-term results as good as TURP or enucleation procedures because we are not doing the job as big or as destructive as the cavitary procedures does. Age old, say for example, the days when I passed my board exams, we used to say the chances of failure of TURP in 10 years is approximately 10%. That rule is there. So even for TURP, even TURP will fail if the patient lives longer because the prostate, whatever we have left out, will grow back. Even the holmium enucleation, even though the surgeon is very good up to capsular enucleation, there is a possibility of regrowth because the surgeon will leave some prostate tissues here and there. But fortunately, since enucleation is enucleation, we get much better cavity and the chances of the regrowth of prostate causing a good symptomatic recurrence in that patient's lifetime is quite remote. That's why the enucleation is going to be the new gold standard for present and the future. So now this has given a little bit of idea about where the mist stands, why there is a failure, and where the cavitary procedures stands. And just to give the list of mist which is now well accepted by the guidelines, by FDA, etc. We have discussed quite extensively about Eurolift and Resume. When I came to Pakistan, the PAUS 2023 meeting also, we presented about both Eurolift and Resume. I've done a few times online also. The other thing which is now coming up very well is iTind, which I did with the Hyderabad section of PAUS quite recently. Possibly in the future also we will try to discuss a little bit more in depth about iTind. The other two mist procedures which were growing very nicely are the Optilium and the Eco Laser. I don't discuss them much because the topic is different. So Optilium is a kind of a urethral balloon based device where we dilate the prostatic cavity, create a cut at the region of 12 o'clock, and by using the paclitaxel we create a kind of apoptosis to create the prostatic cavity. Again, there are beautiful videos, and if I got enough opportunity, I will present Optilium on a different day. Similarly, Eco Laser is a thermal ablation by using the laser, and we'll discuss these techniques in detail on a different presentation. Why there is a need for mist? First of all, let us just go through some basics. So the symptoms a patient presenting to us were broadly divided into voiding symptoms, storage symptoms, mixed symptoms, and retention symptoms. If you say voiding symptoms, it means patient has got symptoms like weak stream, hesitancy, interruptions, etc. We call it as due to bladder outlet obstruction. If you take storage symptoms, it could be due to two different etiopathology. The first one is secondary to bladder outlet obstruction. So if you do urodynamics, sometimes you can say that there is some hypercontractile hyperactivity in the detrusor, but it is secondary to bladder outlet obstruction. So these patients, if you do mist, they do well because we are addressing only the bladder outlet obstruction. Indirectly, it will help the bladder to recover its contractility, and then it will help with the storage symptoms also. But sometimes the patients may present with pure primary hypercontractile bladder due to the lifestyle changes, caffeine intake, high pressure working, increased sympathetic tone, etc., etc. So those patients have nothing fault in the prostate. So whatever you do for the prostate, their storage symptoms should not improve. It's like apple falls due to the gravity. Whatever you do, that only will work. So the mist procedure works only in the prostate. So if a patient presents with the storage symptoms, you should be absolutely sure that the storage symptoms are secondary to bladder outlet obstruction. Urodynamics is a very important tool in this aspect to be confident of this thing. If there is a storage symptom which is more bothersome for the patient, but the storage symptom is not the reason for the patient's bladder outlet obstruction, then obviously the treatment of bladder outlet obstruction will not help in the storage symptom. Patient will need some medications for the storage symptoms. So that I will discuss further. And then there comes the mixed symptoms. Again, mixed symptoms could be like a voiding dominant mixed symptoms, storage dominant mixed symptoms. Quite clear. Anybody with mixed symptoms, voiding symptoms will be addressed. Storage symptoms, if it is secondary to bladder outlet obstruction, they will be addressed. But if the storage symptoms are primary hypercontractile bladder, unfortunately, we won't be having good improvement with just mist alone. Coming to the retention, it's now very clearly proven acute retention patients and to some extent acute on chronic retention patients do well with mist, especially in Eurolift. We have got quite strong evidence of Pulsar study where it has shown that acute retention patients, those with good bladder function preserved, they do well with the Eurolift. But chronic retention patients, again, the fault is not in the prostate. The fault is because of the bladder where the contractility is gone. So those patients will not respond to mist, and not only will not, they should not respond to mist because we are not addressing the primary pathology. And similarly for high pressure chronic retention, the pressure is so high in the bladder, it got transmitted via the ureter into the upper tract, resulting in the hydronephrosis and loss of the kidney function. These group of patients should not have mist. They should have absolutely cavitary procedures like TURP or any enucleation procedures so that we create as much of low pressure in the bladder and we preserve the kidney function as much as possible. I hope this gives an overall idea of mainly two things. The mist will address only the bladder outlet obstruction problems. If there is a primary pathology in the bladder, mist will not work. And if there is a combination of the primary pathology in the bladder and something in the prostate or bladder neck, we need some ancillary medications. Okay? Now, the main four areas where mist were quite popular and why it's become very topic of the world is patients are not in need for TURP or holmium ejaculation. The prostate is not big enough. For example, if you start them on say tamsulosin, alpha blockers, it's brilliant. It's working very well. The patient feels like, doctor, I'm peeing like a horse. I have no problem at all. But the problem comes due to the side effects. Any medicines have side effects. So tamsulosin, as we know, we have side effects like, for example, postural hypotension, asthenia, nasal stuffiness, etc. Or in case if the patient is on 5-alpha reductase inhibitors like finasteride, it can cause problems like lack of libido, erectile dysfunction, etc. So patient says, doctor, my water works is brilliant. You have given me the tablet which really made me feel 10 years younger. But unfortunately, I have these side effects. So what to do? We can't force the patient to suffer from side effects, which is equally as bad as any voiding symptoms. So these patients will be served by mist. The other thing is failed medical management. Somebody will fail quite early itself, within 3 months or within weeks of starting the medication, stating that it never worked for me. But for some patients, these medicines work for 5 years, 10 years, 15 years and then stopped working because the prostate has overgrown or the patient's sympathetic tone has become different. Another thing is economics. Patients find difficult buying these tablets every day, week on week, month on month. They say, doctor, can you do one procedure? I'm happy to shell out some money and solve it. I can't pay this monthly pharmacy bill. And the most important thing, as we discussed, is these symptoms are now present in very young population, and those who want to preserve erection and ejaculation, our own tablets of tamsulosin, which can cause dry ejaculation, as we know, and also the finasteride, which can cause significant problems with libido and erectile dysfunction. The tablets are not doing any good. And here I want to explain clearly the side effect of tamsulosin of retrograde ejaculation is little bit of a misnomer. So the best or the latest evidence is tamsulosin, just like how it causes relaxation of VUJ, relaxation of bladder neck, relaxation of trigone, relaxation of prostate. It also relaxes the ejaculatory duct. So it's more of an ejaculation, because for proper ejaculation to happen, the ejaculatory duct should have the preservation of the peristalsis, smooth muscle movement, etc. Tamsulosin, because of the alpha blocker, causes atonicity of even the ejaculatory ducts that results in anejaculation. So the side effect of retrograde ejaculation is very much outdated. So if you come across an examiner who is quite updated, they may quite ask you on these kind of aspects. So now, the need for the medical management post-MIST comes into play because of the surgical retreatment rate after various new MIST procedures. It depends upon which article, which resource you are looking into. This surgical retreatment rate varies. There are lots of sponsored studies sponsored by pharmacies. So if there is a study which is sponsored by pharmacy companies, say for example Boston Scientific, they may come out with a study saying that resume as the least retreatment rate, while others have more retreatment rate. And similarly, every company has its own publications. But I've just googled and took this particular abstract from AUA from 2021, which showed on an average retreatment rate per year. The values are quite upsetting. Per year, the retreatment rate for UroLift 5.4, TURP 5.3. So gone are the days where we say 10% retreatment in 10 years. Now there is a retreatment up to 5.3 every year. And the green light again 5.2, resume 7.2. So there is a very big need for retreatment. There are various reasons behind it. Number one, maybe the surgeon may be in the learning curve. Number two, maybe like a wrong selection of the patient. Number three, maybe like a wrong technique. So there are lots of reasons for this retreatment rate. And as I said, if you look into a different publication from a different country or a different kind of practitioners, these rates will differ. But one common thread is there is a good amount of alarmingly high retreatment rate. This is one reason why professor asked me to take this topic to see what can we do for these patients who need retreatment. Or they really need to go for another surgery, or can we again balance it out by using some medical management. Now, post-MIST, any MIST procedures, we can divide the patients into three groups. One group, excellent improvement. Patient discontinues all the medications. If the patient previously on a catheter, like acute retention patient, he is free of catheter, he really appreciates you, he comes and gives you a chocolate and a greeting card, patient sorted. How long he is sorted is another question. It may work for 1 year, 5 year, 10 year, we don't know. But at least patient had excellent outcome, patient is happy to get discharged and go back to his normal life. We want all the patients to be in this first group, which unfortunately won't happen in the real life practice. The second group is the moderate improvement, where they will say, doctor, I'm feeling okay. The nighttime symptoms are better. Previously, I used to get up 10 times in the night. Now I'm getting up only once in the night. It's better, but it's not, I won't say it's brilliant. I won't say it's 100 out of 100. So these kind of patients will get benefit from, say, alpha blockers or 5-alpha reductase inhibitors, anticholinergics or beta agonists. So this is the main crux of today's presentation. And this medical management, again, not necessarily the patient needs to take for long term. These medicines can be restarted maybe for even short term or maybe for slightly longer term. So this is where the question of whether the medical management after the MIST procedure is really necessary The answer is yes to selective patients with moderate improvement or unsatisfactory improvement. At the same time, which one to give, you need to re-evaluate the patient's symptoms. So patient may initially presented with significant mixed symptoms of voiding and storage. Now the voiding is completely okay. He say, doctor, the flow is brilliant, but unfortunately he still have frequency of symptoms. It takes some time for the bladder to get the retraining that there is no bladder outlet obstruction. There is no need for bladder to be hyperactive as before. So it takes some time even after TURP or whole mean enucleation for the bladder to improve. That's why a lot of patients with whole mean enucleation can develop significant stress incontinence, and it takes some time for the bladder to get retrained and the stress incontinence disappears later. So in that period, patient may need some anticholinergics or beta agonist, or sometimes even with a combination of tamsulosin. And also some procedures like, for example, eye tint, it produces a lot of edema in the prostate, and initially once you remove the eye tint implant after 5 days or 7 days, patient will struggle and they need to continue the alpha blockers or 5 alpha reductase inhibitors, whatever the medicines they are taking, at least for a few weeks to get the confidence of voiding without tablets. In my practice, what I tend to do is, if I'm doing a urolift, if we have to do an eye tint or resume any procedures, if the patient is already on tamsulosin or finasteride, I will ask them to continue at least for 3 to 4 weeks. And it really helps to kind of bridge the improvement and slowly wean off the tablets, rather than stopping the tablets on the day of surgery, putting the patient into multiple stress like local anesthesia, hospital visit, missed procedure, stopping 5 alpha reductase inhibitors, stopping the alpha blockers, everything at one go spoils the patient's comfortness. Okay, so there is a definite need for missed either short term or long term. And I've come across some patients after urolift, they say, doctor, the flow is brilliant, I'm very happy and thankful for this, I'm able to sleep well, there is no problem with erection, the ejaculation is maintained, everything is fine. And then when you ask further questions, are you still taking tamsulosin, they will say yes. So if I ask you, why are you taking tamsulosin, just stop them, I don't think you need them. They try to stop them, but they feel that added tamsulosin gives them more confidence. They are able to have good holidays, they have good flow, etc. They say, it's not bothering me anymore. I'm really struggled a lot with tamsulosin. It's never gave me the quality of life. Now with urolift, my quality of life is so brilliant. Why we have to stop the tamsulosin? Why can't I continue? And my side effects are not that bothersome. So there is a good group of patients where we may have to continue the medications in spite of the missed procedure. If I take back, say, 30 years back, 40 years back, if a patient had TURP, if the patient need to take alpha blockers post TURP, that means that's it. It's a failure of TURP, because we want TURP patients to be absolutely medication free and they should be completely voiding on their own. That's the success of TURP. But this mist is not as powerful like TURP or enucleation procedures. Since we are quite minimalist, we need some additive support from the medical management also. Unfortunately, sometimes you will come across the third group, which there is no improvement from the procedure. It's absolutely failed mist. Patient definitely needs TURP or anatomical endoscopic enucleation of the procedures. I hope with adequate patient selection and adequate training and appropriate mentorship, the third category should not happen. The third category happens means it may be a wrong patient selection or wrong technique selection, and those things should not happen in our normal life. So if a surgeon is completely nicely trained, he has know the pros and cons of all the missed options available, his outcomes should be like 70 to 80% in the first category. Excellent improvement, no need for medicines. 10% patients may need some support from medical management, and the chances of failure should be nil. Maybe 1% to 3%, which can happen irrespective of the techniques, etc. Okay. So, is medical management post missed means failure? I don't think so. So, in the era of TURP, if a patient is going for a whole beam enucleation or any enucleation procedures nowadays, if there is a need for medical management after that, especially alpha blockers or 5 alpha reductase inhibitors, it's not a good sign. But sometimes the patients need anticholinergics or beta agonists because of the bladder symptoms. But for mist, sometimes patients may also need to continue tamsulosin and 5-alpha reductase inhibitors. I won't say it's a failure, it is a new norm. Maybe this is what we are discussing in the conferences. This is the feel from the surgeons who are doing quite high volume, minimally invasive surgeries for prostate. But whether it will be acceptable in long term, whether it will penetrate into the guidelines, etc., we need to wait and see. So we have discussed quite clearly how mist is differ from the TURP or anatomical enucleation of the prostate. Both are entirely different. Lot of times the mist is marketed as just an alternative to medicines. So instead of getting into the surgical realm with lot of side effects of say bleeding, need to stop anticoagulants, etc., why can't we balance or bridge so that the patient will push the TURP or the whole beam enucleation to a later decade? Maybe it will save another 10 years of life. So mist bridges the life till little bit elderly age. It preserves erection and erectile dysfunction as long as the patient needs, which is the major winning post for the mist. And for many patients, obviously, it has become a very nice long-term solution also. So many thanks for this opportunity. I'm quite happy to answer the questions. Best wishes.